So as Jamie explained to you guys, what we're hoping to do is a little bit of a round robin, getting your thoughts about the pre-record and the RAND report, and thoughts that you might have about implementation strategies, that, ideas given the implementation complexities based on what you've learned. So why don't we just get started? And Janine is here to, clarify, answer questions, help us move this conversation along. So anybody who wants to start, since we're such a small group, please go ahead, and let's just make sure that each of us has each of you has an opportunity to contribute and help us think more about these implementation challenges.
Well, I'll go first. Bevan McLeod here. I felt like it was very helpful to hear that, implementation or taking smaller chunks and incremental steps actually might end up being much more costly than doing it all at once. And so I think from my perspective, I would like to really focus on shifting it in one big movement rather than trying to tiptoe over the next several years and adding populations as we go. So given that, I think that talking through these administrative pieces is going to be really, really pertinent to what we recommend to the legislature. And I think that I hope that we get more than just today to discuss these. I feel like any one of those pieces that was on the list there could take our full 3 hours of discussion. So I hope that you guys will send those lists out to us so that we can actually work on that outside of this meeting and come forward with some really thoughtful recommendations on how to administer. And in terms of the feasibility, I think once we have a sense of the cost and the savings and how those savings can be allocated, and can wrap our minds around the administration of this, the feasibility in my mind politically is going to be much easier right now than it would have been even 2 or 3 years ago. Just given the fact that we're sitting in this pandemic and everyone is understanding, unfortunately, how deep the inequities are in the current system. So I will leave my comments at that.
So this is Janine. I just want to clarify that last bit. So you sort of also are you saying that you would like to understand how the implementation administrative choices could really impact the savings?
Yeah, I would like to understand that, definitely how they would impact the savings, but I also want to see, as the RAND report kind of delineated, I would really like to see what, based on our analyses that have been done, what kinds of savings are allocated where. So based on what we saw today, how much of those, up to $3 billion savings is going to occur at, let's say, a state administrative level, right, versus individuals. So, I'm just thinking from a political perspective, when we can go in and tell policymakers, the state will save X amount of dollars if we go with this, I think that is very helpful in the feasibility of getting this done.
Mm-hmm. Right. I mean, from my point of view, as if I was a state legislature, you're feeling the pressure, as we see in our public comments, of people not getting quality healthcare when they need it, right? We know about that pressure, but what we haven't talked about so much is the pressure on state and local coffers, and that is really coming to bear right now. And at some point, that is going to be a crisis that has to be addressed, and there's going to be a certain amount of obligation to taxpayers to explain whatever it is that we're doing or not doing in regards to healthcare to control the costs. So yeah, I'm interested in seeing that too, Bevan.
So any thoughts about the presentation, that the pre-record and the discussion that Janine just offered around the implementation challenges?
So this is Brenda. I wanted to jump in on what Kelly said and kind of echo it. I think the cost is going to be a big struggle. Right now well, yes, COVID certainly sheds light on the need for healthcare all across the board. It also sheds light on the financial strain that the state's currently under. And so, looking at the RAND report, looking at the 3 different options that they talked about there, a couple different tax models, as well as looking at the potential of the state backing the startup costs, I think there's a big question of where's that money going to come from, and how are we going to, I guess, and this is me kind of brainstorming here, so sorry if it's kind of all over the place, but, is there a way that we can say, okay, it's going to cost X, Y, Z, X amount of dollars to start this up, so that will be repaid through the savings in model, in some of the actuarial models, and there's a pledge, so to speak, to return that money to the state if the state were to start that up, or something along those lines. So it's not just, hey, we want to do this, it's going to cost this much money, please give us the money to do that, and we'll have the operating costs and the running costs maybe through a payroll tax or something, but that initial kind of cost, I think, is going to be something that's going to be really analyzed very closely, especially right now when the budget is in such dire circumstances.
Yeah, Rich, people can just talk.
The RAND report was really important for me. I was a little shaken is a strong word by when the public comments started off with kind of adding a little bit of skepticism, and I'm not sure why, that it's only 4 years old. So that raised my interest, and I was struck again by the public comments that really, they were heart-wrenching, but really what people want is access to care, and there's certainly a smattering there that have so 1 and 2 both achieve that. So I think it's important that we kind of remember as we get other opinions weighed into this, that there's other ways of that access is heart-wrenchingly needed for people, and then the mechanism is a different issue. But what I was most struck by in the RAND report was the footnote for the healthcare ingenuity plan. The footnote said an 8.4% tax would be the highest state sales tax in the nation, and currently California has 7.5% tax. Now, this is coming from a state that has no sales tax. We in Washington State have a 6.5% sales tax. And I don't know, are we talking about additive, 7 plus 6.5? Are we talking about a 14% mind-numbing cost? Because I mean, RAND is a big deal, and it's a nonprofit, and they look like they did a good job. Are we in a position to be able to even think about extrapolating? Because the costs now are probably, if anything, worse.
I've never seen sales tax as a way to fund Washington healthcare. I've seen payroll tax and employer tax.
That's
one reason why the RAND thing was sort of confusing, because it's like we don't have personal income tax and Oregon does. I couldn't quite wrap my head around that.
It's confusing, but it gives me a sense of the magnitude of the magnitude that are going to be needed.
Mm-hmm. Well, you just don't forget that they're already paying a huge percentage on health insurance anyway. Employers are. I mean, it's been estimated $20,000 per employee at Boeing. That's a lot.
Mm-hmm.
Although they do get tax rate
tax break
deductions for that cost. So they are getting some subsidies for providing those insurers for insurance. So there is
even as self-employed, self-insured.
Self-insured, not as much as others, but yes, there's a business write-off for some of that.
Of course, there is.
Yeah. But I think the healthcare ingenuity plan was a particular model that stakeholder there in Oregon had developed over the years, and so since Oregon doesn't have a sales tax, in order to raise the money for it, that was a proposal of that was part of the structure. Again, so it was really more that, though it is an example of the reason we used the RAND was just to think about how your models are so similar. How you pay for all this is a whole nother topic, but what they were trying to think through in the part I presented just now was, you know, what do you want to really make sure gets implemented with this model? You know, access, as Rich was saying, is so paramount right now. We want to, it sounds like, and it has been over past discussions, access is really important. Quality. And so you would want to make sure there was quality management. That's really important. What are the other things that, if you think about how you administer, if you were the insurance guru administering a plan, one of these plans, A, B, or C, what do you want to make sure really does happen out of those qualitative criteria that you had previously thought about?
So what are the options? You could do it, I mean, I've heard by age, I've heard by income.
For age by
rolling
income
people
for
into a new plan.
Mm-hmm. Well, again, it depends on the model, right? Because A, B, and B, it would be that you were probably a Washington resident, so you could be eligible for this, right? As we were talking about a minute ago, whether you want to do that, do you roll everyone in at once? Do you roll in certain groups at first and then add other groups?
I think we're getting some
sort of
feedback from someone.
I don't think it's me, but
It's gone.
okay. Hopefully it's not.
So Mia, it's me. I lost my earbuds, so I'll just, it's hard since I'm the facilitator, but I'll mute for now. Go ahead.
oh, I've had to do that before. That sucks. Yeah.
So I think
Right.
the
That's what I
discussion
was talking
today,
about. Was what are the ways you could that's what's so weird as a universal system. How would you do it by population? I don't understand that, I guess.
yeah, so there's got to be some, so the question is, do you do it all at once? Do you do it partially? But I think that's part of the implementation. But then there's other things. Once they're in there and they're part of the new plan, what do you want to make sure happens? Quality, you want to make sure there's good access.
So there's also the scope of the services that you provide. Is that what you're saying?
Right.
Like you could have the basic healthcare plan.
Yeah. But I mean, we've already done, you know, that's what they've modeled in the model is the basic health benefits. But how do those get administered? How are you going to make sure that Rich is really doing all the screenings that he's supposed to be doing? Of course, he will do them, as Dr. Kovar would, but who's going to, you know, do you want to make sure there's good look at sort of the, you know, do you want the providers to be rewarded around quality metrics, or do you want them just to go provide as much access as possible?
Are we reimbursing them? If we're reimbursing them by outcome or by?
Yeah, do you want to use the current system, which is predominantly fee for service, where you just pay for widgets of being seen, or do you really feel that paying a practice or for a population is the approach you would want to consider?
Rich, do you have any? I don't.
For a universal budget, I think.
I don't have great wisdom into this. I think the movement really moved towards a combination of productivity, provider satisfaction, improvement in quality measures. And I think you can do that. And that's why, I mean, it's hard to see how the independent small practice survives in this. Though that's certainly, this is a regulation issue. And at the top, the entity that's administering this can regulate things so that even compensation is dependent on these really important multiple factors and not just widget moving.
Okay, so Rich,
Right.
that surprises me because I thought it would make it better for independent shops.
I don't know. I'd have to think that through. Again, that's a regulation issue that if people can provide the quality measure improvement, someone's got to be, they have to be in a large database. And if they can provide somehow public satisfaction and quality improvement, all power to those groups. And I would definitely not want to lose that.
But we really have to be careful about like rural health care where it's harder for people to get to specialty care and really think about those providers. I think some kind of cost-based payment. I know, you know, like a federally qualified health center does. I know that people don't like to do cost reporting, but there's got to be a way that we can simplify that to make sure that providers are paid not just for the cost of providing care, but if it's complicated care, they need to be paid more. If they're doing a lot of the specialty care work in their own clinic because these people aren't, you know, can't get in. Hopefully in a universal healthcare system, people have access to those providers, but still in rural areas, you have to travel, you have to take time off work. People don't like to do that. So I think, you know, those cost-based payments are important to think about, even if it's just for the rural providers.
I just to speak to the rural need, to me, I think when I think about this whole process, in my mind, even though I'm an urban provider, I'm thinking about my rural residents of the state. And it just so has to be structured like it's a discipline.
Yep.
How do we always think about rural and access? We have to start, you know, talking the language of telemedicine more consistently, because we're not going back and away from that. Specialty care is extraordinarily more efficient, and much specialty care that's not procedural can be provided by telemedicine, and you can adjust rates, and we just need to be thinking forward, thinking creative, and geographic access is a huge growing issue in the state. It's always got to be front and center of our thinking.
So I think for me, it would be super helpful to hear, you know, maybe from the facilitators to see some different options and different, you know, systems that are similar to what we're talking about in terms of the makeup of the administration and the allocation, so that we can have a base point from which we're starting to think about this as a group. I think if we're left to just kind of individually fantasize about how we might, I mean, there's varying degrees of, you know, participation. I mean, we have providers in this group, we have members of the public in this group, we have advocates in this group. I mean, so many of us are not skilled in administration. So I think it would be super helpful to understand, you know, what are some parameters that we can start from and kind of visualize how we might improve them, or, you know, what we might do differently or really like, so that we can kind of go from there. That would be helpful for me anyway.
I wonder if it would help to go back to those original presentations about different systems that already exist or something and say, yeah, we like this from that. And that.
To me, this is like a giant self-funded plan, really. In my last job, that was one of my tasks, was to move the tribal government and the casino staff from a regents to a self-funded plan. And you can pick all the different things that you want you to pay for in different ways. And I really think, you know, if we have a good model for payment, it makes better sense to use a TPA. TPAs can still do a lot of that population health reporting that might be helpful for figuring out payments. They can do a lot more things. I have to turn my camera off, I think, because my internet's unstable. But I think that there's, I was hoping Jane Beyer would be in this group, because I was wondering if there's a way we can do like a state-based Medigap plan, where the state can get the premiums from Medicare to provide, and I'm sure that would mean a waiver, but I think that might make it, I'm worried about all the federal stuff that they say we have to do in order to make this work. But I really think, like you said, Bevan, if we break down the different pieces of the administration, and they did some in the slides, and think about what can be done. I mean, I don't know if anybody in this group works for a health insurance plan, but most of them are making profit. And so you're paying for a CEO and all the staff. When you pay a TPA, you're still paying for staff and benefits and that stuff, but you're paying for them to process claims, not to take on the risk.
What is
and
a
so
TPA?
third-party administrator.
Folks. Sorry, and I'm sorry if you're getting feedback from me. This is difficult. The question that, am I okay, Mia? Okay. So the question that we need to grapple with here is the implementation challenges given those and I think, Bevan, getting to your point, it's not really looking at line by line what administrative choices we would make. It's given the federal complexities, ERISA and Medicare and Medicaid. Are your minds changed at all about which model to choose? And
No.
that, I think,
No.
right, okay, so people are not saying no.
No.
So I think you just
We
have
know
to be very
coming
clear.
in that there were these problems. It's not a newsflash for us.
So
Right.
let's talk about that, if you guys wouldn't mind, just round robin. Why does it feel, or what's important to you about what you've heard and the path forward? And then, this question of the administrative challenges around, that whole list that Janine presented is, I think, another exercise. And, we can help to tee that up. So if you guys wouldn't mind going around and speaking to, based on the pre-record, and as you're listening to the challenges of, waivers and timelines, what are some thoughts that you have about that? Thanks. I'll mute myself again.
So I actually helped, put feedback into Pramila's first version of the State-Based Universal Healthcare Act of 2018, and worked with Vicki and the American Indian Health Commission as well on the writing of that bill. And I think it's really, really, really important. Maybe we could, I know that Representative Kana Rokana from California has now taken the mantle on that. But really what it does is it simplifies Section 1332 of the ACA so that states would only have to apply to a single waiver, right? And then from there, they could decide, if they didn't want to accept the Medicare dollars, or they didn't want to include, Indian Health Services or VA, that each state would have that choice, but it simplifies it. And so I think it's really important for our work group members maybe to read through. It's a pretty simple bill, honestly. And I think that that's really important to understand, that it's on the docket, right? And it's submitted, it's in Congress, it has co-sponsors, right? So the path forward, I don't think is quite as bleak as some people may think it is in terms of getting the federal support. It's not to say that it's not challenging, it is, right? But the pieces are there.
You say that this is an official request for a presentation about the State-Based Universal Healthcare Act?
I think that it should at least be included in, review items that we send out for our next meeting, so that work group members can read through the bill. And we can help provide that language.
I may agree with Bevan. I think it's an excellent point, but wouldn't that be the same for option 1 or 2? That part of things, getting the federal resources that could either implement 1 or 2. So it's not. I think it's very useful. But I mean, at the end of the day, somebody said, we're an election away from either making progress or game over. So I think we should be optimistic and hopeful, and I don't think that those points decide between the two plans. There are other things that should.
But your question was about implementation, given what we're seeing as needed from federal support, right? Okay. So I'm just saying, I don't think it's quite as dire as we may think it is. I think that there's a roadmap to success there for the states. Especially if we have some states that are ready and maybe want to collaborate. That was a piece of the proviso as well, was to look at, multi-state solutions for this. So anyway,
and I feel like it might even be more politically the right time for the State-Based Universal Healthcare Act after November, if things go well, than ever before. So yeah, I agree with Rich and Bevan that optimistic track is the way to go. Because,
So Janine, in what you're listening to, are there any red flags raised for you around other permissions that would need to be beyond the 1332?
Well, I think, at the moment, you guys are not considering putting Medicare in, although I know someone mentioned about the Medicare gap plan. So
okay, so we didn't say that, though.
State.
We were told that. We were told, I think we need to discuss.
So that's what the current model doesn't have Medicare in it. Right. as an assumption. I think there's still the challenges of ERISA that are more challenges
That's handled in the
that you can't necessarily.
too.
Is that handled in the bill as well? Okay.
Yeah.
So Kelly, do you want to speak to that? You had some, just your Medicare comment. I think that's important to pull forward.
See, I feel like it was a fire hose of information, and I can't speak to that. I need to go talk to people, but I just want to make sure that we realize that was presented to us. We have not agreed to that, and that we need the opportunity.
Sure, yeah.
And we might say yes. That I don't know, but
yes. I think just flagging that though, and I just want to make sure that I understand what you're saying, so that we flag that. That's right. Is Medicare in or out? It's not. You guys haven't said. Clearly we don't understand all the information that was presented by Shane and Jared yet, so that will be important. Okay. Other folks, we have 5 minutes left in this session. So this, question of implementation challenges on the federal level. And it sounds like we've got a really nice glide path roadmap in the 1332. And is everybody feeling like that's, so we're still on option 1, and let's just ride that 1332 option as far as we can go.
Well,
but as you think about A versus B, go ahead, Rich.
I think that's what I was going to say. 1332 is a great roadmap concept, but it can lead to 1 or 2, I think.
Right. So is there any thinking about some of these implementation issues and some of the things that will need to be administered, et cetera, in terms of whether it's state run with perhaps a little help versus delegated out to health plans? Did you think about that? And Bevan has thought about that.
Yeah, that used to be my job, quite literally. I'm going to share in the chat. I just pulled up Rokana's bill, so I'm just going to share the link for anyone who's interested.
Thank you, Bevan. Were you going to comment on?
Yeah, so thoughts, Bevan, about
whether we have to fund everything at the state level versus whether we get some federal support?
No, whether you delegate to health plans in B versus A. Does that make you choose one, or do these administrative and other feasibility challenges have any impact on whether you, how you think about going forward to tell the legislature, let's go do A versus let's go do B?
I would certainly say A. I think that, for simplicity, all of the components that we have listed as necessary for our healthcare system, all of them are good in A and the best in A, right? And I think that even our report today is indicating that A is going to save the most dollars, it's going to give the largest access, et cetera. I think also what we also have to include, which I haven't heard a lot of conversation on, is a just transition that has to be included in these implementation pieces, right? As folks who work in the private insurance industry are displaced, what happens? So is there a retraining program that is included in that, right? If so, how much? If we talk about who's going to administer or how the state would administer, let's say it's the healthcare authority as an example, how many would they need to hire in order to, facilitate something like this? And could people from the private industry, go into that? So there's a lot of pieces of this, right? And when we're talking about displaced workers or jobs that are going to be disappearing, that we have to think about, and we have to think about it from a labor perspective too. And I think that our union representatives in this group have some pretty solid ideas around how we would do that and how we might word that. So I think that's something we also have to think about. And
in terms of that, Bevan, I'm really curious if we could disperse some of that work around the state in order to spread the employment around the state. I think that would be a very good idea.
Yeah. So it sounds like there's a leaning for those who are speaking toward the state administering being the administrative entity versus hiring out and ASO services to a private entity, for example. Rich?
Well, I'm skeptical. I just don't really think the state can do it. I don't think it's capable of performing that function. I think it would have to be contracted out in some way. And that's why I go back to, like, you know, the beginning of this process where we looked at other countries and what they've done. And we have an idea of what kind of overhead is a reasonable. Look at a Germany type of a program, similar to ours. The government pays for it. And it's like at a fraction of what we pay. So you set the limit of where it needs to be, and we figure out how to find the entity that'll step forward, possibly with economies of scale, by much larger enrollment, to perform what Germany does at the cost that they have to pay. So to me, it's a feasibility issue as well as a state competency issue. I philosophically love the idea of number one, but I'm skeptical.
Rich, what do you think about how Medicare did it in 1964 when it came out, that it used private claims processors for 5 years?
I think that
and then they switched over to the government doing it.
Yeah. So a transition plan.
That's possible. But I think that this is in 1964. We have pretty competent MCOs they cost a lot of money. And I don't think we can afford them. But if we set the amount that should be paid, somebody should be able to step forward and provide the service at what it costs plus a few percent.
Yeah. I mean, one example, of course, is Oregon, where we set trend costs at 3.4% for, and everybody who's implementing it has to stay under that. We're doing it in our public employees plans as well as Medicaid. And we have been able to keep under the trend cap, so it means it's a state regulation that the trends being paid out cannot be higher collectively. So there's different tools and levers that states and institutes can use to, again, how do you administer and implement the model?
And so many of us are just angry about the profit issue here, but that's a regulation issue, political and regulation issue.
And we had that debate about profit and nonprofit with our CCOs in Oregon. One of our legislators was really wanting them to be all nonprofit, but we were holding them all accountable to the same requirements, whether they were profit or nonprofit, so they couldn't game the system per se. So we have a mix of them, actually.
You mean like medical loss ratio?
In the last 30 seconds? Yeah. Final thoughts in the last 30 seconds, folks? This was good. I think we got into the stuff we needed to get to here. So thank you.
I just want to say, Rich, I think that your point is well taken. I'm certainly not going to yell if somebody says we can have something at 2.whatever%. I think there's room for creative thinking here for sure.
Yeah.
That's a compromised position, Bevan.
Well, that's information that's information our actuaries can bring forward. Again, just rather than get the big, large, mind-numbing discussion of other countries, lay out their administrative costs and how they're structured.